Right, good evening, everyone. My name is Chrissy Kelly. I am the founder of AbScent, and welcome to our second Zoom webinar. Tonight, I have with me Professor Claire Hopkins of the British Rhinological Society. And I also have with me, as usual, Aidan Kirkwood, who is making us both look good by manning the chat bar, the question and answer bar, and making sure everything goes smoothly. So thank you very much, Aidan, as always. Claire, I'd like to maybe just let you introduce yourself. You can do a much better job at that than I can, so take it away.
So my name's Claire Hopkins. I'm a Professor of Rhinology and Consultant ENT Surgeon at Guy's and St Thomas's Hospital, and I'm currently the President of the British Rhinological Society.
Very good. So Claire, it's great to have you here. We always have lots and lots of questions from the patients in the Facebook group. We've got a long list of things to get through today. So I think maybe we should start right now with the problems. Tell us about what your caseload is like, and how you, as the BRS and as you advise the ENTs that you work with, what sort of steps are you taking? What does that look like for you?
So currently, the best way to describe it is that ENT and hospital services are in a bit of a mess. As of March the 20th, all routine outpatients were completely closed down across the country. Certainly initially in London, it was because we were overwhelmed with looking after COVID-19 inpatients. All of our junior doctors were redeployed to COVID wards, to A&E. So the consultants were left to man the emergencies and cover the wards in ENT and to provide tracheostomy. So we really didn't have time to see any outpatients. Certainly in the last 4 weeks in London, we're starting to see the tail end of COVID-19. ITU is getting a lot quieter. Our juniors are slowly coming back. So we're starting to think about returning to normal practice. But we already have a 3-month backlog of patients who we haven't been able to see. In the last few weeks, we've started doing telephone consultations, remote consultations, and partly because patients were still in lockdown. And we wanted to be absolutely sure that the hospital was a safe environment to get people to come into, and that people have the confidence to travel into hospitals. Obviously, people are still concerned about using public transport and so on. So now we think we've got to the position that we can start to see patients again in outpatients. But suddenly we've discovered that there are a whole host of other problems that we've got to deal with. My hospital is covered over 28 floors, and the lifts are normally very busy. We might have 30 or 40 people in a lift at any one time. Of course, social distancing doesn't allow that. So we've worked out we can have 4 people in the lift at any one time. So we have to have a queuing system just to simply get up to the ENT department. Within the ENT department itself, that creates problems. Our waiting area has had to be redesigned. So we realised that we've had to really restrict the number of patients that we're going to be able to see face-to-face in a clinic. The next problem is how we examine patients, because ENT surgeons are at particularly high risk of catching COVID-19 from their patients because the viral load is highest in the nose. So as you can imagine, if we were to look in someone's nose with a tiny little camera, that can sometimes cause the patient to cough or sneeze, and the ENT surgeon literally gets a face full potentially of virus. And certainly at the beginning of the pandemic, ENT surgeons were amongst the first group to be infected. And sadly, one of our colleagues in ENT was one of the first doctors to die. And so we have to be confident that we're protected ourselves. And I think we've done that now. We've got adequate PPE, and not just for our own benefit, but to make sure that we don't pass infection on to any patients. So patients will be asked to wear face masks in the clinic. We will be in masks throughout. And it's going to be a very different experience for people coming into ENT, but we think we've just got to the point where we're ready to start seeing patients face to face. However, it will be in a much more restricted fashion with much fewer numbers. So our challenge is how we make sure we can care for all the patients who need to see us and access care without too much delay. So we will be converting a lot of clinic appointments to telephone consultations where we can. And we're doing other things to look at pathways to try and give patients advice so that they can self-manage where possible. and to give GPs better information so that they can manage more patients in primary care without the need to send people in. And I think that particularly applies to patients with recent onset loss of sense of smell, really who can do a lot of self-management and can get most of the care that they need from GPs. So I'm sure we'll talk about it in a little bit more detail, but we've been working to develop guidelines really to help patients and GPs do that more effectively so that most patients won't need to come into ENT at all.
Right, right. Well, and I've put out a poll today. The first poll that we have, we're hoping to have some other polls for you a little bit later, but the first poll that we put out was about how many of you have actually spoken to a doctor about your smell loss, or even are there any among you who have seen an ENT for that? So if you do take some time to answer that poll, I mean, certainly the impression that I'm getting right now from patients is that they're just either afraid to go in or feel that their doctor wouldn't necessarily take this, consider this an important thing, considering what else is going on. So you've mentioned the new guidelines. Now, what do you think, what can patients expect?
Well, certainly we want to make sure that patients can see their GP and have confidence that a GP will know what to do. I think, you know, there aren't many silver linings from the pandemic, but what we hope will come of it is that we can use this as an opportunity to educate GPs and ENT about anosmia and how best to treat it. So what we've done with the guidelines is we've looked at all the available evidence, really from studies of post-viral loss related to pre-existing viruses. Coronavirus has long been known to cause loss of sense of smell with a typical common cold. So we think a lot of the evidence that we use from post-viral loss in general will apply to COVID-19. Obviously, we can't be absolutely certain, right, and we're learning as time goes on, but it should likely apply. So we've taken the best available evidence, and with a panel made up of the British Rhinological Society Council, we've tried to make guidelines that we think best fit, and both in terms of making sensible use of the available resources and making sure patients get the best care as soon as possible. So first of all, we've looked at what patients can do themselves, and we've made it very clear in the guidelines the first step for all patients is to contact groups such as yourself and Fifth Sense to get advice and support, because that's really important. You know, I'm preaching to the converted, but what a lot of patients tell me is that they find it quite difficult to get not sympathy from their families, but their families just find it really difficult to understand the impact, and it's really important to be able to share that with people in the same position. And certainly we want to raise awareness of the impact it has on patients with GPs. You know, I've heard some awful stories about patients being told by their GP that, you know, it's just not that big a deal, or, you know, it could be worse. And we really want to educate and try and stop that. So, for example, we hope to have an article coming out in the BMJ next week where we publicise the guidelines, but we've also included a patient's experience, and he very, very nicely highlights how isolating this is and how important it is to recognise that. So we've put out a patient advice sheet that patients can access through the ENT UK website, and we're very happy for you to post that, and directs patients to patient support groups. And we encourage patients to look at smell training very early on. So again, I'm sure anyone listening into the call is likely to be on that already, but, you know, huge lack of awareness about smell training in primary care, and we're really trying to promote that to make sure that all patients are advised to use that really early on.
Yeah.
We are encouraging GPs to confirm the diagnosis. Now, in terms of testing, if you have lost your sense of smell in the last 3 months, it's such a good marker of COVID-19 that you almost don't need a test. We can be 97% certain that it's related to COVID-19. But people like to know, they want that confidence that it is COVID-19 and it isn't something else. Obviously, the ideal is to have a PCR swab within the first 7 to 10 days of losing your sense of smell. But the problem for most people is that the UK hasn't been very good at testing. And early on in the pandemic, before we got the government to recognise loss of sense of smell, and that was a real battle, the only way you could have a test really was if you were ill enough to be admitted to hospital and you had cough or fever. So a lot of people won't have been able to access tests, but what we know from studies is if you have a PCR test within the first 10 days of losing your sense of smell, if we take all patients, over 90% will test positive for COVID-19.
And do you think that the tests are really that reliable? I mean, do you feel confident with, how do you feel about a negative result versus what are the chances of a false negative versus a false positive? And how do you see that? Because a lot of people have said, I tested negative, but I really don't believe that. I think I had the virus.
The test is certainly not 100%. The sensitivity may be only as good as 70%. So, for example, if we really want to rule it out for a patient in hospital, we need at least 2 negative swab tests.
Really?
So a single negative test certainly doesn't rule it out. The test result becomes negative really as quickly as 10 days after the onset.
Right.
Now, so you want to get the PCR test as quickly as possible to give it the best chance. But it's quite a difficult test to do. You have to get the little brush high into the nose to sample it. And a lot of people doing the tests aren't trained in the anatomy of the nasal cavity, and they will find it difficult to get the swab to the right place. So certainly it's not 100% reliable at all. Right. If patients have missed that first window or the test was negative, then the other option is antibody tests. Right. But the problem with antibody tests is you don't develop antibodies till 3 or 4 weeks after infection, so you can't rely on them too early. And the antibody test, if you test positive, is 100% reliable. But again, you can have false negatives. And what we found when we looked at patients who we were absolutely certain have had COVID-19 anosmia, they've had a positive PCR test, that at least 15% of those patients don't develop antibodies. So even though they've had the infection, they haven't been able to mount an antibody response to it. Mm-hmm. We don't understand why. So that's as many as 1 in 8, 1 in 7 people will have a negative antibody test, even though we're absolutely sure they've had COVID-19. So again, it can't be relied on. So, the reality is if you've had sudden onset loss of sense of smell, particularly if you've had other symptoms, in itself, that is probably more reliable than any of the tests, but we would like to be able to confirm it for patients' peace of mind if we can. Yep.
I mean, I myself, so I had COVID-19, or at least I believe I did. I had the classic symptoms. I lost my sense of smell again. But there was no test available to me, and I will just be, a question mark. What I do hear a lot in the group is that people get antibody tests. They test positive with a swab 4 weeks, 6 weeks, 12 weeks after they lost their sense of smell. Now, do you have any advice on that? Because of course everyone is thinking to themselves, am I still a carrier if this is what the tests are saying? And these are people who've had multiple tests.
Yeah.
Well, what do you think about that? What's your advice?
So we found the same when we looked at our cohort of patients who we've studied sort of on a weekly basis. At least 1/3 still had positive PCR tests 4 weeks after losing their sense of smell. Gosh. Now, what we find is the viral load drops very quickly. So just because you have a positive PCR test, it doesn't mean that you're infectious. And the reason that we in the UK advocate 7 days of self-isolation after positive test is that even though you might have detectable virus RNA on a viral swab, your viral load is too low after 7 days to be infected. So although it's concerning that you're testing positive, it doesn't mean that you're infectious to other people. The most recent evidence that's come out is that in patients that continue to test positive, most of the virus RNA that's extracted is dead. So it's an inactive virus that's almost clearing from the system, that we think. Right. So the need to test negative perhaps isn't as important as it was first thought at the beginning of the pandemic. But what we don't really understand is whether persistent positive tests might link to other things. So first of all, there seems to be no correlation between the persistence of loss of sense of smell and negative swab tests. But what we don't know is perhaps whether some of the other signs, Porosmia, might be linked, for example. We just haven't yet had the chance to look at that.
Is there a way of looking at the swab test results to determine whether the virus is active or dead?
Not done routinely, but it's being done in research studies. So not in our group. We're looking at patients. We've now followed our patients up to 12 weeks and we've been doing persistent tests, but we haven't looked at whether the virus is live or dead. But it's coming out in other research studies that when patients continue to test positive, it appears to be dead virus rather than active virus.
Right. Good. Now, I just would like to draw everyone's attention to the question and answer panel that we have. So we've got 3 questions up there right now. And I'm going to save the nasal spray question for a little bit later. But Elaine has asked, if I had a COVID test negative 7 days after onset of anosmia, am I less likely to present positive for antibodies? Is there a relationship between the 2 tests?
We think that the higher viral load means you're more likely to test positive. So, it's hard to tell. As I said, it's about 1 in 8 maybe don't seem to test positive on antibodies. They haven't mounted a sufficient response. And it does seem to be the more severe the infection, the more likely you are to have to develop antibodies. So if you've had a very mild infection, you're more likely to fall into the group where you don't seroconvert.
Okay. There's another interesting question here that's come up. This is from Juan Alberto, and he says, is it normal that it takes longer to return my sense of taste than my sense of smell? So I think maybe we should just clarify at first on the difference between the sense of taste and the sense of, and the experience of flavor. But I have heard this described often enough that I am beginning to think that maybe some people are able to perceive, have retronasal olfaction and therefore experience flavor when they're eating, but for some reason they're not experiencing orthonasal olfaction. Would you like to clarify that a little bit for the audience and maybe give us any thoughts that you have on that?
So first of all, when we describe loss of smell and taste, what we usually refer to only is loss of smell, because our true sense of taste really only allows us to pick out the difference between sweet, salty, sour, bitter, and something called umami, which is a really difficult thing to describe, but it's a sort of a meaty taste. And so when we lose all of our sense of flavour that normally comes through retronasal olfaction, we breathe out through our nose, and we would report losing our sense of taste, but we haven't really. What's actually really interesting with COVID-19 is that we do get true loss of taste as well as true loss of smell. So we get anosmia and ageusia, and that's actually fairly uncommon. What we've seen in a study where we've looked at patients every 10 days with objective smell and taste tests is that actually taste seems to recover first, true sense of taste, and then sense of smell recovers about a week, or starts to recover about a week or 2 later, at least in the majority of people.
Right, good. Okay. Robin asks, it seems that many people are still experiencing missing or distorted smell weeks or months after COVID has resolved. I'm at day 100 and smell is still up and down, muted on some days and distorted on others. This is common in my support group, but how long is it expected to potentially take to fully recover? I'm hearing 6 to 12 months. What do you think about that?
So if we take post-viral olfactory loss as we used to see it, the majority of patients wouldn't present to ENT usually for 3 or 4 months. And what's really unusual about COVID-19 is because of the awareness, people are consulting at a much earlier stage. Now, when we look at the data for post-viral anosmia, the patients who typically present to ENT at 3 months have about a 30% chance of having recovered by 6 months, and about a 67 2/3 will have recovered by 18 months. So about 50% overall at a year. Now they're quite a different group of patients because we've already taken out all of the patients that make an early recovery. So when we come back to COVID-19, we have a really unique opportunity at the moment to be able to get data from a very large group of patients. So we are learning very quickly. So we've been studying altogether in the research cohorts that I have going about 3,000 patients with very regular testing. And what we've seen is that about 60 to 70% of patients will recover very quickly within 2 to 3 weeks. And these are patients that we would never have normally seen either in primary care or in secondary care, because when you typically get loss of sense of smell from a cold, your nose is very blocked. You don't think much of it. You can't breathe through your nose. And by the time your nose is cleared, the loss of sense of smell is likely recovered at the same time. With COVID-19, it is quite unusual because it's not associated with the obvious nasal obstruction. But most of that group, if we take out the sort of 2/3, will recover within 2 to 3 weeks. When we look at patients at 8 weeks, we've still got about 5% of people with complete loss of sense of smell, anosmia, and another 5% of people with reduced sense of smell, but about 90% have fully recovered. Now, if we think in the UK, 2.5 million people have had COVID-19, probably that's 2 million people that lost their sense of smell if we look at the data. So if we take the 10% will have persistent problems at 8 weeks, that's already 200,000 people in the UK who will have at least ongoing symptoms by 8 weeks.
Yeah.
What I think when we get to the group of patients at 8 weeks is they probably reflect the recovery rates that we've seen with post-viral loss. So now it's going to take weeks and likely months to see improvement, but we would expect there to be ongoing recovery.
Mm-hmm. And I think that's an important message. Certainly in the Facebook groups, there is a lot of anxiety, people coming in who are really very worried. Naturally, there's a lot of media coverage of smell loss, so they know what the word anosmia is. They're coming into the group and they are very, very worried because everyone else is talking about, you know, I'm on day 100 and I haven't recovered. So I always try and remind people that, you know, typically we might expect recovery to take a couple of months. So I think that's, you know, that's really important. What does seem to be new is that there are a certain group of people who are getting back. They're getting back their sense of smell. Sometimes there are fluctuations, and I'd like to ask you about those fluctuations in a moment. But they are finding that their sense of smell is returning, and it feels real to them, so there are no distortions and everything's feeling fine and they're feeling healthy. And then suddenly out of nowhere, they're getting Porosmia. So I know that this is not necessarily the usual course of events. Do you have any thoughts on that? And you know, do you think that we continue to support and advise patients who have this in the old way, that is to say, based on what we used to know about Porosmia?
So coronavirus in the past would make up about 10% of viruses causing the common cold. So a relatively small fraction, but we did see Porosmia in patients with post-viral loss in the past, but in much smaller numbers. Coronavirus is quite an unusual virus, and it's something that we would describe as being neurotropic. And essentially that's a medical word to describe something that has the ability to invade nerves. And invade sounds a terrifying word, but essentially that's what it does. It passes along the olfactory nerves to gain entry into the intracranial cavity, into the brain. And it replicates within the olfactory bulb, the olfactory nerves itself. And that's how it spreads. And so it's not surprising that it causes damage to the nerve fibers. Now, the reason that we have the ability to recover is the olfactory nerves are quite unique in the nervous system in that they have the ability to recover. And in health, we replicate and turn over our olfactory nerves every 30 to 120 days. So that's where we see that timescale coming in for recovery. So a lot of people, I think, that get this very early recovery have simply had an injury to the olfactory epithelium, the lining inside the nose, and that recovers very quickly. For the rest of people who've lost their sense of smell, it's a sign that the virus has got into the olfactory nerve itself, and therefore you have to regrow the olfactory nerve endings. And this is unique to coronavirus in comparison to rhinovirus common cold that just affects the lining inside the nose. And so as those nerve fibres regrow, they're not working very well while they are newly formed. And so they have to regrow and then mature into fully functioning nerves. And it's while they're in that recovery phase that I think you get the Porosmia. Now, you know, we need to do more studies, but we're already starting to see papers emerge in the literature in the last few days that show, for example, MRI findings that show the olfactory bulb is inflamed in the first 2 months. So we know it's certainly getting into the olfactory nerve itself. And we're starting to see some histology reports showing virus within the olfactory nerve. So all of the evidence is starting to fit with our theory as to why this is happening.
Certainly, one of the things that comes up a lot, I just had a private message today from someone who describes this incredibly, just sort of incredible headache kind of right here behind the bridge of the nose, that I wonder, you know, do you see that that might be a manifestation of something like this?
Yes, I think there are a lot of odd symptoms. You know, it's the burning pain, the burning tongue, people are getting tinnitus, they're getting dizziness, headaches, a lot of neurological symptoms which reflect the fact that the virus does get in, you know, throughout the whole body. It primarily affects the lungs, but it's having an impact on the brain and the central nervous system itself.
Yes, burning mouth syndrome is another one that's come up quite a bit, sort of tingly tongue.
Yeah.
Okay, so we've got a lot more questions. I think what I'd like to do now is ask you about treatments. What treatments do you think might be useful? And maybe we could start with this first question, which is, I've been prescribed a metazone furanate nasal spray by my GP in case of inflammation, but I've heard that some doctors do not recommend steroid spray, so I'm not sure whether or not I should use it and don't want to lose what smell I have. Do you recommend that or not?
So unless you've got a very blocked nose, then a nasal spray is simply unlikely to help. And what we know from studies is that nasal sprays on their own aren't particularly useful. In the first 2 or 3 weeks, you may get some inflammation in the nasal cavity high up where the smell nerves sit. But the problem with that is a nasal spray isn't really going to get up there. And the only thing that's going to help get up there are nose drops or rinses. But that is only likely to help in the first 2 to 3 weeks. The problem is mostly in the smell nerves, which are on the other side of the skull base. So they're within the brain itself. And a nasal spray just isn't really going to get there. So the only form of steroid that might be helpful are oral steroid tablets. Now that in itself is fraught with lots of problems. So what we know from the MERS coronavirus is that if you have steroid tablets, it delays clearance of the virus. And certainly you don't want to be taking any oral steroids in the first 2 or 3 weeks because it might slow down your recovery. The question is then, if your loss of sense of smell goes on for more than 3 to 4 weeks, probably those would be people where I would consider very carefully whether oral steroids would be indicated. But oral steroids have lots of side effects, regardless of their impact on viral clearance. You can get thinning of the bones, it's immunosuppressive, it can give you stomach ulcers, it can make you ravenously hungry, so they can make you put on weight. In very rare cases, it can cause damage to the hip bones. So you have to think very carefully about using oral steroids and discuss the risks individually with a doctor, because they'll be different for every person depending on any other coexisting illnesses. But oral steroids do have the best evidence to be helpful. And I think particularly around that 3 to 4 week phase, because what I think they do is they reduce swelling and inflammation within the olfactory nerves. And I think they give the nerves a better chance of recovering without coming across scar tissue and other things that might prevent recovery. So if you're going to use them, I would say around the 3 to 4 week mark, partly because then a lot of people, 90% will have already shown signs of recovery. And if things are already improving, I think you don't need them. But if at 3 to 4 weeks there's been absolutely no sign of improvement, that would be a good time to discuss using with your doctor. We simply don't know how long it's worth considering. So if you're at 12 weeks whether the window is being missed, we really don't know from any studies. But certainly they're not for everyone. You know, you do need to consider the risks and benefits and discuss that carefully. And your GP should be able to prescribe them, having been through that with them.
Right, right. I know so many people describe these fluctuations, which is, from my experience, not what we would expect in a typical sort of post-viral recovery scenario. These people are describing waking up in the morning and having no sense of smell all over again. And then as the day progresses, getting back to whatever level of recovery they had the previous day or 2 days ago. And so that they have these fluctuations that take them from 0 to a certain level of recovery. And I mean, what sort of scenario do you imagine that could be creating an experience like that?
Well, certainly some of we generally expect blockage in the nose to be worse in the morning, because when you lie down at night, all the tissue inside the nose engorges, so the turbinates swell up. So you do get a conductive anosmia first thing in the morning. And if your thresholds are reduced because of underlying COVID anosmia, any reduction in airflow and delivery of odorants to the top of the nose are going to have an impact. So I think that fluctuations that we're seeing are partly due to change in airflow in the nose itself, rather than sort of an hourly change of inflammation within the olfactory bulb. And what people could try would be a decongestant, for example, first thing in the morning, not on a regular basis, but just to see what difference that makes in their background sense of smell.
And when you say a decongestant, are you talking about something like Sudafed or?
Yeah, just as a one-off, because if the decongestant is helpful, that's when I would think a nasal spray might have a useful role. And you can buy nasal sprays such as Flixinase over the counter, so you don't need to see your GP. So using a decongestant once or twice to see if it makes much difference to the fluctuations might be a good guide for patients to then know whether it's worth them using a spray such as mometasone on prescription or Flixinase over the counter.
And just to clarify, Flixinase is also a steroid nasal spray. It's not
Yes.
one of the sort of decongestants like Otrivin or something else.
No, Otrivin decongestants you should only use once or twice, not on a regular basis, but Flixinase is a steroid spray. The compound in it is something called fluticasone, very similar to mometasone. The good thing about both fluticasone and mometasone is they have very little absorption into the bloodstream, so they're extremely safe to use.
Right. That's important to know, and I think important to stress the difference between the two kinds of nasal sprays, because I'm aware that some people in the group have described overusing some of these nasal sprays, which are not healthy in the long run. So
decongestants, certainly, if you use for more than a week, they start to cause more problems.
Yeah, that's right. Yeah, good. Okay, so let's get back onto some more questions. Let's see. Hamad has made raised an interesting question. So this is an article that was in the Medium. He says, if you lose your sense of smell taste, you are unlikely to have any serious complications due to the coronavirus. It's a protective mechanism. Do you have any thoughts on this research?
So that came from friends of mine in San Diego, and they looked at about 1,000 patients, and they asked patients to self-report whether they'd lost their sense of smell. And what they found was that sense of smell occurred more commonly in about 70% of the people who had a mild course, compared to about 30% of people who had needed to be hospitalized. So they proposed that it was a protective sign, and actually, if you lost your sense of smell, you could almost sort of stop worrying because it was a sign you weren't going to get severe illness. Unfortunately, I don't think that that's the case. And I think the problem was that if you imagine a person who is very sick in hospital, who is needing to be ventilated, they're not eating and drinking, they're not tasting, they're not smelling because they're being ventilated. And we know that 70 to 80% of people will recover within 2 weeks. Now, patients who are very sick with COVID-19 typically spend 2 to 3 weeks on a ventilator. So the most sick patients will actually be ventilated throughout their period that they've lost their sense of smell. And those who are very ill but not ventilated, may simply neglect that they can't smell and taste because they've got no appetite and they're not eating. So to try and get a better feel for that, we did objective tests on patients with both mild, moderate and severe disease. And we found actually that the prevalence of loss of sense of smell is exactly the same across all of those groups.
Oh,
and
really?
we then did a forward study where we took patients at diagnosis and measured their sense of smell, and then we monitored them moving forward using oxygen levels, temperature probes, and looking at how many patients were hospitalised. And we found that it's not a predictor of how you're going to suffer with your COVID-19. And it's simply what we call recall bias in the most severe patients, that they simply overlook their loss of sense of smell, or they're too sick to notice it while they've got it.
Right. Very interesting. Okay, so let's see. Elaine has asked whether or not there are any research studies that in the UK that patients that are looking to recruit new patients.
Not yet, but I'm working on it. So I am hoping that we'll be able to run some trials for different treatments, and we're just working out the protocols and proposals at the moment. So we will certainly let you know so you can share with the group.
Yep. Yep. So for any of you who are listening who are not part of the Facebook group, I recommend, and you don't do Facebook, I recommend that you go to the abscent.org website. Maybe Aidan will be good enough to write that down and send it out to everyone who's listening. You should go to the abscent.org website and sign up for our newsletter, because we will be giving out information on all these things in the future. So that will be a good way for you to stay in touch. Right, we had another question about fluctuations, but I think we've answered that. Right, so someone has said, I tested positive for COVID antibodies and have not had full smell for 2 months. I can, however, smell certain objects if they're placed right under my nose. Does this mean I have hyposmia instead of anosmia? And does this also mean my olfactory nerve is still working and has a chance of full recovery?
So yes, it's a threshold problem. You've got a reduced sense of smell, but the nerves are working. So you need odorants to be delivered at a much stronger concentration. Now, one of the things that you can do if that's the case is you can use a simple saline spray immediately before meals or just before smell training, such as Steroids, because when we breathe in and smell, odorants have to dissolve in the mucus layer over the lining of the nose before they can get to the smell nerve endings. And actually, if you use something just like a saline mist, it helps the odorants dissolve into the mucous membrane more quickly, and therefore you get a better delivery of odorants at meal times. So you can bump up your threshold a little bit just using a saline spray. Obviously, it's a very temporary effect, but when you need it most for your smell training or your meal times, that might help. And what we've seen from all our studies looking at recovery is that the patients that have mild to moderate loss actually are doing the best, and all tend to go on to get good recovery. So if you do have some sense of smell at 8 weeks, that's a really positive sign, and we can be reasonably confident that's going to improve further.
Right. And is that the same principle of the sodium citrate study, or is that a different effect?
I think sodium citrate seems to do a little bit more than just saline rinsing, because in the studies they did use saline rinsing as a control, but we found even saline rinsing on its own immediately before mealtimes does have some beneficial effect. I think sodium citrate also changes some of the sort of electrical impulses and passage of odorants over the membrane.
I wasn't aware of that. Thank you very much. Let's see, what else do we have? It's not able to access. Okay, let's go down. We've got lots of questions. Okay, Elaine has asked, is it normal during smell training that you can smell something, but you don't actually know what the smell is? If you look at the label before you smell, then you can pick up the smell slightly better. So I know what I would say about that. What do you think, Claire?
Well, I think when you've looked at the label, you're using some of your olfactory memory to superimpose how you think it should smell on that. So, you know, we do have a very strong olfactory memory, and, you know, you only have to look at a bottle of Johnson's baby powder and I think of smelling my children when they were little, because it brings back all of those emotions. So, you know, I think that's why it seems to be better when you know what it is.
Yeah. Right. I apologize for the barking dog in the background. Let's see. Somebody's asked about vitamins. Omega-3, vitamin C, B vitamins, and NAC, which is N-acetylcysteine, something that's been discussed rather a lot in the Facebook group. What do you think about whether or not they are helpful? And I'm just going to turn off my video for 1 minute and sort out the dog. So Claire, I'm going to talk.
We looked at all of the evidence from trials for different types of olfactory loss, particularly post-viral loss. There were some trials for zinc supplements, which were actually quite interesting because it suggested that the patients in the placebo arm that was getting a blank tablet actually had better outcomes than those taking zinc. But the trials did use quite high doses of zinc. But that certainly tells us that you shouldn't take more than the daily recommended dose. So I do recommend to all of my patients that they take a basic multivitamin and mineral to make sure that they get the full range of things that the body needs to recover from any illness. In terms of specific supplements, there is some evidence from a very small trial without a control arm that vitamin A drops may be beneficial. But vitamin A drops in the nose are actually quite irritant, and it stings quite a lot when you put them in. And when the British Rhinological Society Council considered the evidence for vitamin A drops, when we looked at the recovery rates in the trial, we found that actually the outcome was no better than sort of natural recovery. So we haven't recommended those. Omega-3 is really interesting because it hasn't been studied in post-viral loss, and that's certainly one of the things I'm trying to get into a trial. But one of my colleagues from Stanford, Zara Patel, used omega-3 in a study of patients having radiotherapy to their smell nerves. Now, radiotherapy actually causes quite a similar injury to the olfactory bulb that a viral infection would do. It causes inflammation and the nerve has to regenerate. So although it's quite a different situation, it kind of mimics what we expect is happening at the moment. And what she found was that patients who were given omega-3 supplements had much better smell outcomes than the group that had radiotherapy without supplementation. There are some other really interesting studies. You can create what we call mouse models that lack certain genes. And somebody has created a mouse model where the mice don't have a gene for omega-3 receptors. And they've worked out that these mice have no sense of smell. Oh. And you can also look at population studies where you can look at rates of anosmia in the population relative to their diet. And what we found is that patients living in Mediterranean countries who have a very rich omega-3 diet actually have better olfactory function than countries where the diet is low in omega-3. So all of these things together make us think that omega-3 might be protective for the olfactory nerves in some way. So, you know, it hasn't been trialled in viral loss at all yet, but there are very few side effects from omega-3 supplements other than their slightly funny fishy taste. So it's certainly one of the things that we've recommended as an option in our BRS guidelines, and it's something I recommend to my patients.
Very interesting. Very interesting. Right, we've got another question about Tamiflu and whether that would be of any assistance if someone felt they were just coming down with the virus.
To be honest, that is out of my area of expertise, but having been keeping a very close eye on the literature, it doesn't seem to have any benefit.
Right, okay. I have a question that's come up quite a bit. I've been contacted privately with this question as well. The question is olfactory training useful for those with Porosmia?
Well, I mean, my feeling is that Porosmia is a sign of recovery, and it's those immature nerves that are regrowing and not fully functioning. And the more we educate them to function properly, the better the outcome. So in my mind, and I don't have evidence to back it up, that transition from no smell to some recovery to Porosmia is a time to really step up the smell training and focus on it even more. It can be difficult if the smells are unpleasant. and you more likely to have tips and tricks as to how to overcome that. But I say to some people, if they really can't stand the smells when they're doing the smell training, they might chew some menthol gum or something just to try and mask the porosmia so they can still do their smell training.
Absolutely, absolutely. We've had a long discussion thread about this recently. More and more people are talking about porosmia now. And I think that, and then I went into my my so-called old group and I said, what advice would you have to give to these new people who are turning up with porosmia? And one of them is to try cinnamon toothpaste, cinnamon chewing gum, cinnamon sweets. For some reason, that seems to be a smell or a flavor that is acceptable to many porosmics. And we do think that there are certain foods that are acting as triggers. We have some idea of why that might be, why these foods. But if you find that you've got foods that you do not respond well to, then the best advice I can give you is to avoid those foods. Yeah. The other thing that is, I think, very obvious is that room temperature or cold foods don't have as much smell for obvious reasons. Volatile molecules don't come off them so quickly. So that can be a help. But certainly avoiding things like deep fried food, that's often a culprit. Frying meat, frying onions, actually raw onions as well. There are certain categories of foods that are really bad, and you just need to avoid them. I'm preparing a list of these sort of suggestions from the AbScent group. So at some point, I will be bringing that to you in the Facebook group as well as on the website. So if you are affected by porosmia, we will be doing everything that we can to help you. So I hope that you will come by and avail yourself of all the things that we've put together. But first of all, I've had it very, very badly myself, so I know how awful it is, and I know what a challenge it makes, not only eating for yourself, but also if you're in a family situation where people are expecting to sit down at a table with you and eat. It can be nightmarish and make every day miserable. So yeah, and we are thinking about this a lot and trying to find ways to help you. So we will be giving you more reports on that soon.
If the porosmia is really disabling, if you get to the point where you can't eat with it, there are some medications that can be helpful, but they are a type of epileptic medication that does come with side effects called gabapentin. So it's not something to use unless you're really struggling. But if you are struggling, and some people really do, then speak to your GP, be referred to either ENT or a neurologist.
Right.
And they can discuss medication with you just to dampen it down.
Right. Jackie says she seems to want to eat more with now that she's got no smell or taste. And what do you say about that?
Well, we've seen losing sense of smell and taste can do one of two things to weight and appetite. It can either make everything taste the same and people lose their appetite, or the body is searching for that satisfaction it used to get from flavors. And so you keep going and looking for something else that will replace the enjoyment in the same way. And because the body isn't getting that feedback, it looks for something more. So that's not uncommon, unfortunately.
Yeah.
It's important. And again, groups like this are really important to get tips on how to find that enjoyment from your food, whether it's adding texture, simple things like putting popcorn into soup so you've got some crunch in it instead of the flavour. Not taking the easy option of adding salt, because obviously that's very unhealthy, but experimenting with chilies and other things that will replicate some of the feedback that the body gets from flavour in the past.
Okay, let's see. A question from Craig, who would like to know, to what extent do nasal polyps impact on recovery from COVID-19 smell loss? So what do you think about that?
So nasal polyps obviously cause what we call a conductive loss of sense of smell. The polyps grow in the olfactory cleft and they simply stop odorants. I don't think having polyps is going to change the recovery in itself of the nerves, but obviously it will change your thresholds automatically, it's much harder for odorants to get to the nerve endings. So if you've got pre-existing polyps and then you get a further loss on the top, the two are going to combine together to make it very difficult. Now, nasal polyp treatment is hopefully improving in the near future. But again, with nasal polyps, it's important to get the right treatment. Nasal drops usually much better than sprays to really get them up to the olfactory cleft if you're trying to target your sense of smell. So you really want to optimize the care of your nasal polyps and make sure you're seen by a specialist in ENT with an interest in nasal polyps. And then hopefully in the not too distant future, we'll have the additional treatments such as biologics for that. But that's probably a separate topic, but really optimizing the care of that to allow as many odorants to get through to those injured nerve endings as possible.
Right. Just two short questions on that. The use of biologics for smell loss, for polyps in this country, we're not quite there yet. Is that correct?
No, I was involved in meetings with NICE, the organisation that approve new drugs. The last meeting was in February, and things were progressing reasonably encouragingly. We were due to have a final answer in July of next year. There are several stages of the process that we have to go through. We were really trying to convince NICE of the importance of sense of smell, because that's where biologics really do better than anything else. And they were just starting to get that. And I think one positive that might come out of this is that we know that many government ministers have lost their sense of smell. Many people in important positions now know exactly how it feels to lose their sense of smell. Right. So I think it will be easier than ever before to convince people of what a big deal this is. So we're going to use that to our advantage. The only downside is that the NHS will be bankrupt more than ever before. And these drugs are really expensive. They cost about £2,000 a month. So what restrictions they will put on use, and we don't yet know, but I suspect that they will only be available to patients that have had probably at least 2 operations and get their polyps back, but I just don't know for sure.
Right. And if I could ask you about the drops that are sometimes useful in these situations, do you recommend the Kaiteki maneuver, or do you recommend another method of application of drops?
So it's really up to individual patients to experiment as to how they find it most comfortable. Certainly what you don't want to do is sit in a chair, tip your head back and pour the drops down your throat, because that is going to give you all the side effects. So either lying on the bed with the head back or kneeling forward on the ground with Kaiteki and the drops to go in. But experiment with both, because some people just find one easier to do than the other.
Okay, thank you. Okay, so Marina says, I've been smell training for about 7 weeks, and although in the beginning I could not detect the smells, I am now at a point where there is a smell, but it is similar and rather unpleasant for most smells. Is this normal?
Yeah, I mean, that's some recovery coming, and your threshold's going to improve. And, we recommend smell training for at least 12 to 16 weeks. So it's frustratingly slow, and it's just a case of keeping going. Some evidence that changing the odours at around 12 weeks might be helpful from Thomas Hummel's studies, but it's really just perseverance, I'm afraid.
Right, okay. Christina has asked, she said that she's able to smell a little bit from one nostril, but not the other. And her GP says it doesn't seem to make sense. I hear that a lot, that they have Porosmia in one nostril and not in the other.
So in the patients that we have studied with objective tests, we did find about 3 or 4% of patients that actually only had anosmia on one side of the nose. Now, there's no reason why in some people one nerve is affected more than the other. The other thing is that about 70% of the population have a septal deviation. So automatically you get better airflow through one side of the nose than the other in 2/3 of people. And if you have a threshold problem, if the nerve is injured and you need a high concentration of odorants to get to the nerve endings, if you have a deviation in the nose, it may not be bad enough to really affect your ability to breathe through the nose, but it might be enough to change airflow and delivery of odorants high up to the nose. So I think that's probably the most likely reason.
Right. Okay. I think we'll take one more question, and then we're sort of getting to the top of the hour. let's see. One woman, Suzanne, has written to say that her daughter, age 13, has COVID antibodies and is on her 11th week with no sense of smell. She's being treated with steroid nasal rinses and started smell training, but can COVID-19 permanently destroy the sense of smell?
Well, I can't say specifically for COVID-19 because we're all at the same stage with our experience, and the longest data we have is at 12 to 14 weeks. But unfortunately, with other viruses, in some patients it is permanent.
Yeah.
Now, I think the younger you are, the better you recover from anything. So her chances of recovery are good. The nervous system is regenerating all the time. So, you know, it's really difficult at that age. Certainly we've seen fewer patients in teenage years and adolescence, but there is still a significant number. But I would be optimistic for her chance of recovery.
Right. Good. Well, I think we'll finish now with the questions, and it's just, I'd like to let you know that the recording of this event will be put up onto YouTube in the next couple of days, and you will be able to see it again and take notes if you weren't able to do that this time. And for the next couple of weeks, we've got some very interesting programs coming up. In 2 weeks, I'll be speaking with Dr. Jane Parker of the University of Reading about Porosmia. Again, she and I are working on some research into Porosmia, and we were closed down. The lab had to close when COVID-19 came to town, but we are finding innovative ways of carrying on with our work. So I hope that you will tune in and we can talk more about Porosmia then. And then I have I've got some patients lined up to discuss their particular cases. And so do please join us for these Tuesday evening Zoom sessions every other week. So I would like to say thank you very much to Claire for spending an hour with us and letting us hear your expertise. Thank you very much. It was a pleasure to have you. Aiden, it's always nice to have you with us managing in the background. And Claire, if you do have anything else to say before we sign off?
You know, I'd just like to say there are a significant number of ENT and researchers who really care about anosmia, not just because of COVID-19, but we are here to advocate for you. We will keep researching, we will look to ways to help. And just to let you all know, if you find that your own GP or ENT doctor aren't particularly helpful, you can ask to be referred on. But also you can download the guidelines and I'll make sure that Chrissy puts them available. So don't be afraid if you go to your GP to take them with you and say, you know, I wonder if you've come across this, because GPs are in an impossible position at the moment. They are bombarded with new guidance on everything from COVID toe to COVID hair loss. And it's almost impossible for them to keep up. So, you know, help them to help you, take the information along and don't be afraid to ask them to have a look at things specifically that you've come across in groups like this.
Yeah, that's right. Yeah, absolutely. Thank you, Claire, for that. So we'll see you in 2 weeks, everybody. So thank you for attending. Good night.
Good night.